Ready. So stop projecting. No input. Just give us 5 minutes. We just sort this out.
Start it. I'm calling people just to do the starting.
We need the IT guys.
IT call. It's all password. They can't call it. I don't get my life. The next outside for that.
Slide. So, wait. Step number 1, step number 2. Gotcha. उसी के slide show. Set to piece only. Yeah, try that. But he said you don't put it as a slideshow. It will affect. I just want it to be as a screen. Maybe I just scroll from here. Can you project this one?
Notification do you it means I'll have to check the settings Zake so that I'm able to. If I do that, it'll affect the next presentation we use the laptop.
So you tell him that we can't do it.
I'm not doing
just indicate the screen.
He's saying we have to put it as slideshow.
No, do not put a slideshow. If you do that, you're not gonna. It's gonna mess up with this moment.
Hello. Yeah, again, I'm in a presentation. I'll call you. I'll come there around 3 p.m. I'll be there. It doesn't project that way.
Extend make a pull slide and I'll go there. As much as make extend, I'll pull the slide to there.
Goodness.
So there, I think that's okay.
But there's a problem here. All of them address. Let's see if it works. Let's hope it works.
That's okay. So I'll just go and start. Just switch it.
Is anything here?
Yeah. I'm just going there to the presentation.
It's already there.
Huh? Oh, it's already there.
So what you do is all you need to do is scroll down with this.
Oh.
Up, down.
Oh, just it, okay, very good, good, good. So, okay, please, fine. So, good afternoon, everyone. Good afternoon. My name is Dr. Arib. I'm a plastic and reconstructive surgeon. So, first of all, I would like to thank the team at Jalaram for allowing me to present today, and also thank you to our team from Globe Pharmacy for sponsoring this event. So today we'll go through principles of wound management. We see wounds from pediatrics to the elderly to adults. We see them in all forms, in all fields, from orthopedics, gynecology. So it's something that cuts across, but we thank, as plastics, we thank God that it's our department. So today I'll take you through some principles which I think are very important for us to manage patients on a day-to-day, especially those that we see in outpatient, and then we'll touch a few for inpatient as well. So basically, what's a wound? It's just breach in continuity of the skin. It can come in many forms. It could come in as a laceration, as an abrasion, but anytime there's a breach in the continuity of the structure and impairment of the function of the skin, then that becomes a wound, and that's an example there of what a wound looks like. How do we classify wounds? Basically, there are ways that we do it. One is by looking at the duration. So when you see the duration, you could either categorize this wound as acute and chronic. So in terms of the specific definition, when you look at literature, acute means basically it's going through its normal phases of wound healing, and we'll go through the phases of wound healing, and usually they give it a sign of 4 weeks. For chronic wounds, between 4 to 6 weeks, there's no evidence of healing, and these are wounds that fail to progress. So they start at the phase of hemostasis, and then they're stuck in the phase of inflammation. So basically there's no progression through the phases. All right, so it's not only the duration, so you have to look at where the wound is. Okay, and we'll go through some of the signs of each. Other ways you can classify wounds, you can look at it as etiology. You could look at, for example, you have vascular issues, both venous ulcers, arterial ulcers. You also have diabetic foot ulcers, which are quite common. Based on trauma, injuries, and then based on the depth, it could be superficial, partial thickness, could be full thickness. So basically you're looking at the structure of the skin, so the epidermis, dermis, and the hypodermis. So that way you can gauge where your depth is. Other ways we can look at it, you have a surgical classification. I think some of you have come across this: a clean wound, a clean contaminated, contaminated and dirty. And then we have other specific classifications, which I've just mentioned for sake of completeness. This is the clean, contaminated, dirty type of classification. You can see the base, basically when you look at inflammation, see there's no inflammation in the clean contaminated. Contaminated is inflammation that's apparent, and then here it's severe inflammation. So the ways you can look at it and classify it. So basically, there are some phases of wound healing we need to go through. So you look at it from a molecular point of view. Once you have that initial injury, there are some dermal capillaries, dermal vessels that break open. So that's the first stage. So that's the stage of hemostasis. It usually is immediate within the first few minutes. Your platelets will migrate, you'll have your immune cells, and you have a clot formation. Second phase is the inflammatory phase. This is now where your immune system gets activated, and it has a role basically to get your antigens to be presented and to mount now a proper inflammatory response to get rid of whatever is going on there. Then you have the phase of proliferation. So the chronic wounds get stuck in inflammation. So there are some microorganisms that secrete specific factors that keep the wound fixated in an inflammatory state, and these are wounds that basically you have to go in and debride. That's why we say this wound is for debridement, and this wound is for skin grafting, this wound is for flap cover. Basically you're looking at the structure. If there's a very high rate of inflammation, that's a wound that needs to sort of, so to speak, calm down. Okay, otherwise you'll not be able to get your graft to take or your flap to cover. Phase of proliferation. Now once the immune system has done its job, you now bring in the builders, which is now the fibroblasts, the collagen that comes in. Now you have new vessels that are forming. Then from there, from the proliferation, now you have remodeling. Now remodeling is now those wounds that have like a very light pink scar. That's a very immature scar. So that is the phase of remodeling. Okay. So basically these, if you understand these phases of wound healing, you'll be able to pick what intervention you need to do. If it's hemostasis, you need to augment the hemostasis, basically put pressure, get the wound clean. If it's inflammatory, either you debride or you use antibiotic impregnated dressings. For proliferation, now that's the phase whereby you need to intervene. Either you need a skin graft, a flap, or cover, and then remodeling is now depending on which site it is. This is just basically how wounds get stuck in chronic phase. So basically you have tumor necrosis factor alpha. So that's usually secreted by the immune system, and it keeps the wound in a very bad cycle. So it doesn't progress out of that cycle. You have interleukins 1B, 1 beta, and interleukin 6 as well. What they do is they activate neutrophils, macrophages, and mast cells, and then whatever is contained in these cells, the proteases, the inhibitors are released, and that is now the cycle. That's just basically what's happening. You have now destruction of your proteins, your growth factors don't work, you have degradation of your extracellular matrix. This is also the collagen that's there. You have reduced cell migration. You know, your keratinocytes, your epidermal cells have to migrate from one side to the other. So this is what's happening in the wound, okay? So that's why it's stuck in a chronic phase. What are some of the factors that affect wound healing? Whenever you see a patient who has a wound, these are some of the things that you need to assess. For example, is it smoking? Is it alcohol? Are they on some sort of drugs, hormonal drugs, even some drugs? Basically, you have chemotherapeutic drugs as well. Chronic diseases, including diabetes, hypertension, advanced age, and then hereditary, things like Ehlers-Danlos syndrome, collagen syndromes. Then you have local factors, which is now the wound itself. You can look at the extent of damage, whether it's physical, chemical, look at the pressure on the area. This, for example, when you have a pressure ulcer, you have a wound that's broken down, but the patient is still lying on that area. Compromised vascular perfusion, you could look at it in terms of arterial or venous, all right? And then neurologic deficits, that comes in together with diabetes, where you have your peripheral neuropathies, and then of course you have infection, okay? So basically when you're taking your history in the OPD, these are some of the things that you need to bring out. So sometimes we focus so much on the wound that you want to dress it and the patient goes, you see the wound is for debridement. This patient could actually be on chemotherapeutic drugs. Patient could have a chronic disease, or it could just be age. As you age, everything slows down. So again, you need to make sure you get a very, very good history, okay? And bring out as many systemic factors as you possibly can. Good. Okay, good, thanks. The other principle, if there's a slide that you need to concentrate on, this is a slide I want you to leave this discussion with. So there are 4 things that we look at. We look at the tissue, we look at the infection, we look at the moisture balance, and we look at the edges. If you can categorize a wound and get these 4 factors on a piece of paper and study them, then you're able to get a way of your plan of management. So for example, let's look at the tissue. So how is the tissue? So now you're looking at both the edges and the wound bed. So how is the tissue? Is the tissue viable or non-viable? All right, that's the first thing you need to look at. Secondly, you need to look at infection or inflammation. Is there any infection? Is there any inflammation? How do you look at this? You look at the sign of exudate, you look at the amount of slough, the amount of necrotic tissue, smell, any change in color of the exudate, you look at the color of the tissue, biofilm formation. Those are the things you need to look at in terms of the infection or inflammation. Moisture balance, you need to see, is this wound very dry or is it very exudative? Okay, because everything for dry wounds cannot be used on exudative wounds, exudative wounds cannot be used on dry wounds. Okay, then you look at the edges. So edges, you can see whether the edges are contracting, so whether they are coming together as you dress the wound, or you look at it in terms of, are you suspecting a malignancy? Are they very everted? Are they abnormal? So those are things that you look at. So if there's a slide that you need to go home with today, this is the one. So again, acute versus chronic, these are some things that we mentioned. In acute wounds, you have now expression of alpha-5 beta. In chronic wounds, you have suppression of that. So that's why it's stuck and it will never epithelialize. All right. So what are some of the cellular features of chronic wounds? This is still at a molecular level. So once you see that there's chronicity, this is what's happening at the molecular level. So one, mitotic activity is very low. Impaired migration of keratinocytes. They're not able to migrate. Keratinocytes are the stem cells for the epidermis. Okay, they're found at the basal layer, and these are very important. They come from the bulb of where the hair follicle is. That is where we get our stem cells for the epidermis from. Okay, you have decreased fibroblasts. Fibroblasts are the builders. That's the cement. They give the granulation. That thing we always call granulation comes from fibroblasts. And then again, the response of fibroblasts and the senescent cells as well. So I don't know if you guys can see here, there's usually this yellowish exudate that we see. It's not really an exudate, but it's a layer that forms. That's actually slough. So what is slough? Slough is just basically fragmentation of dying cells because of impaired blood supply, and it has a lot of fibrinous tissue, pus and proteinaceous material. So basically that's what slough is. So that's that material that you see. And once you know what it is, then it has to come out, isn't it? So this cannot stay. So now already you're thinking, okay, this is slough, it has to come out. So you just don't wash the wound and put a dressing. You see this, it has to come out. So whoever is dressing the wound, just do some gentle debridement if it's possible under local anesthesia, or if the patient is not in too much of pain, then you can just go in with a curved scissor, just get that layer out, okay? So that way that has to come out. So microorganisms are usually present in the wounds. So you have these different definitions. So there's contamination, colonization, local infection, and an invasive wound infection. So a contamination, the microorganisms are present, but they're not replicating, all right? Colonization, they are replicating, okay? But there is no damage yet. Local infection, there is that critical point where the bugs are now replicating and getting to 10 to the power of 5. So that is when you take a biopsy of the wound and then you measure the colonies. So they have to be 10 to power 5 and above to confirm that there is active microorganism infection in the wound, okay? Then invasive wound infection is now when you have now your total damage of the wound, okay? So that's how it usually progresses. So what is biofilm? So biofilm is this glistening, layer that is found on the wound. And I have a picture here of 3 wounds. You can see, I don't know if it's very clear, maybe this one is clear. You can see this glistening surface. I don't know if you guys, is it clear? And then compare it with this. And then compare with this. This is not too clear, sorry for that. But here you can see there's a very clear shiny surface that is absent here. All right. So as long as you have that layer, no matter what you put on top of the wound, it will not penetrate the biofilm. Okay. That one has to be mechanically removed. And that is one of the signs of a chronic wound. So whether you use Actisob, whether you use a paraffin gauze, whether you use iodine, research has shown it doesn't penetrate biofilm. The best treatment for biofilm is debridement. Okay, so already you're now making decisions. So you see, now you know what you're seeing and now you're making a decision. All right, so it's not just to come and then clean and then you think it's very clean, then you put a dressing. You're not helping the patient. Okay, so biofilm is usually secreted by organisms. They come in, they sit. It's a proteinaceous extracellular matrix that they create. It's like a shield that they form, and then it layers across the wound. That shield has been shown initially silver could penetrate it. So there's some silver dressings you can pour on top. It's been shown to actually create pores and help. But the best is mechanical surgical debridement. Okay, so that layer has to come out. If that layer is there, no matter which dressing you use, the most expensive to the least expensive, is not going to help. Okay. So how do you manage these wounds? So this is how I usually just categorize wound management. So once you know what it is, and we have gone through the steps of examining, taking a history, and now you know that this wound is ABC. So you have local management of the wound, systemic management of the wound, and then wound closure. So what used to happen before, wounds were just debrided. So somebody comes, you debride the wound, you dress. Again, debride the wound and dress. So there was no end goal. The end goal for a wound is closure. That is the success of wound management. How quickly and how successfully can I close the wound? So you start by your local management. You can either debride the wound or dress the wound. Okay, there are two options. Systemic management, this is now, if it's a vascular issue, you need to get whether it's an arterial issue, whether it's a venous issue or a lymphatic issue. Okay. Number 3 is the closure. So how can I close this wound? Can I put a skin graft? Can I put a flap on it? Okay, a flap is, it comes with its own blood supply. Or can I use biologic substitutes? Okay, these are synthetic materials that we place on top of wounds that integrate themselves and become part of the body. Okay. So this is what you should have in your mind when you're looking at a wound. If you want to manage the wound successfully, these are the steps that you need to follow. So debridement, how do we debride? We irrigate. You can irrigate the wound. So for irrigation, there's a certain pressure that we use. So when you're flushing the wound, don't do it too robustly, because what that does is it opens up a new tissue plane. So when you flush the wound with a bit of pressure, you'll open a tissue plane, and now bugs can go in. So irrigation should just be gentle irrigation. Okay, there's a scientific pressure, but again, it's difficult to measure it when you're doing it as an outpatient. So just gentle cleaning of the wound. Okay, so just irrigate. Whether you can use normal saline, Ringer's lactate, there is literature out there, you can read it, but irrigate the wound. Okay. Surgical management, again, is debridement. That's where we go and surgically excise necrotic and dead tissue. Enzymatic debridement, we use now molecules. Okay, papain, debridase, sulfur-sulfadiazine. Those are the ones that those are the enzymes that we use. And then we have biologic, where we can use maggots. So these are patients who are very sick, ICU patients, but they can't go for surgery. But again, you need to do something for the wound. You can place maggots on them. Okay. Biologically bred maggots. Okay, not the ones that we see in the wounds. Good. So wound dressings. So why do we dress a wound? Because we're always talking about wound dressing. So why dress? One, it speeds up the wound healing because you have a mechanical barrier. Okay. Number 2, it increases the wound strength. How does it do that? You have a mechanical barrier on top. So if the patient goes and hits somewhere, at least there's that cover on top. So you're giving it a little bit of, so to speak, some strength. Cosmetic appearance, again, it looks better if you have a dressing than you walking around with an open wound. It's able to contain the exudate. Again, you have the dressings that are able to absorb, so it's not leaking everywhere. And then it provides pressure for hemostasis. Remember our first phase of wound healing. And then dressings also eliminate pain. Sometimes you have exposed nerves at the wound bed. As soon as you get some air hitting it, you get a bit of pain, some touch. So it's able to eliminate pain. Okay.
Oh, sorry, I lost.
No problem. So we are together. We're together till now. Good. I've tried to simplify it as much as possible. You can see I've stayed away from the boring science. I've just tried to really simplify. So what are the factors that will now dictate which wound dressing to use? So this is important as well. So already we know we have followed our time principle. So we know the tissue, we know the infection, inflammation, we know the moisture, we know the exudate. So some things that can aid in that is one, the location. Okay. So if you have a dressing, let's say a wound on the ear, you have to figure out how you're going to place a dressing there. Okay, if you have a wound on the face, again you need to figure out what sort of dressing. You can't put an abdominal pack or a gauze. Yeah, it looks very ugly. The other reason I put location there is, for example, you can have a wound on the eyelid. So is this a wound that you want to do, or you want to take to theater and find a solution for it? Again, if you have exposed vessels at the base of the wound, that's not a wound that you can place dressings. The abdomen, if you have exposed gut, that's not a, something you can put dressing. So location is very important. Number 2 is the presence or the risk of infection. It will now dictate whether you will use just a film dressing that's non-impregnated with antibiotics, or you're going to use an antibiotic impregnated dressing. Necrotic tissue, again, will dictate to you whether I need to do this surgically or non-surgically. Okay, we can always combine dressings, so you can use 1, 2 together. There's no harm in that. Okay, the exudate, so am I going to use a gauze, an impregnated gauze, or am I going to use a foam? Am I going to use a fiber dressing? So these are some of the things that we need to ask ourselves. Yeah, not to put Actisob on everything. Size, again, will dictate, and then the depth as well. Okay, so some are deep. So when it's deep, you need to fill the cavity. So you can't put a gauze dressing. So you need to get something that is heavy, that can fill the wound, because the body doesn't like dead space. So once you have space, you'll have exudate buildup, you have now infection. Patient-related factors, again, these are the systemic issues. Some patients are allergic. They get, allergies to iodine, allergy to some antibiotics. So that needs to be sorted out. The product itself, is it available? Is it affordable, for the patient? Those are the economic factors. And then the healthcare practitioners. Who is doing the dressing? Is it the nurse? Is it the clinical officer? Is it the doctor? Is it the plastic surgeon? So those are some of the things that you need to consider. So some of the dressings, so if it's like an abrasion or it's a cut wound that has been sutured, you can put in something like this, like a nice film dressing that can absorb a little bit of the exudate. Just place it on top and then see the patient in a couple of days. When do you change a dressing? You change it when it's soaked. Okay, number 1. Number 2, you have lengths. You can go to lengths depending on how much exudate there is. So you can do 3 days, 5 days, 7 days. And then how early have you seen the patient? So when you see a wound earlier, you'd rather put a dressing and then come back a bit early rather than leaving it for too long. So you need to also see how your wound is behaving. Okay, so these are some of the dressings. There's a film dressing. These are the foam dressings. They're quite thick. They're able to absorb some of the exudate that comes in. They're very good for cavities as well. So deep wounds with a lot of exudate, infected wounds as well, because some of them are impregnated with silver. So these are some of the options that you can use. Okay. Hydrocolloids. These are dressings that are present as well. They're highly absorptive. So for highly exudative wounds, you could use the hydrocolloid dressings as well. That's another option. Hydrogels, if you want to donate moisture to the wound, if it's a dry wound, if it's with an exposed bone, it's really dry, you can use a hydrogel. If you don't have a hydrogel, the simple KY jelly, the sterile one, just put in lots of KY jelly and then put a dressing on top. Okay, so that's usually a substitute if you don't have the hydrogel. Fiber dressings, these are for moderate exudative wounds. These are the likes of your Aquacels, Aquafibers. So this is where you can use them. Very good dressings as well. Then you have your gauzes. So your gauzes, they can be antibiotic impregnated, betadine impregnated, or chlorhexidine impregnated. So again, you need to decide what exactly you're doing. So I like using the betadine impregnated dressings, the gauzes. They're quite good, and they'll discuss some of it with us, and the antibiotic impregnated gauzes as well. Okay, so they have some antibiotics in them, really good. So they'll discuss and let us know. So what are some of the biologic alternatives for wounds? Amnion. This is from the placenta. You can treat it chemically and then use it for wound cover. Okay. maggots. You can use maggots as well to debride the wound. Okay, so usually they're bred at Kemri. You go buy them, usually about 6,000 shillings. You come with them and then you individually place them. So they're usually like grains of sand, of rice, and then they puff up. Yeah. So if you want to lose weight, don't eat. Good. Honey this is not the honey that we harvest or we have at home. The honey that we have at home has botulinum toxin in it. So if you place it on a wound, there's risk of botulinum toxin infection. So this is medicated honey. So we have medicated honey that can be used. Honey is the only, so to speak, antibiotic that has no known resistance to it. There's no known resistance to honey. Okay. Then we have leeches. Leeches are used specifically where you have, we use it when our flaps are congested. There's a lot of congestion, so you can come in and put leeches. They can suck out the excess venous blood. But we don't have them in the country. Leeches, I've not personally used them at all. We have something called negative pressure wound therapy. It's a misnomer. The pressure is not negative to the atmospheric pressure. The pressures go up to about 120, 160. So it's basically a foam. This is the wound. It's a foam that you place in, and then you have a suction tubing attached to a machine. So you can calibrate the machine to whatever pressure you want, whether continuous or intermittent, and it has served plastic surgeons very well. It's something that we use temporarily or in the interim where you want to make a decision whether to do a flap or a skin graft. It's an 80-year-old and you can't do a major surgery. You can put a vacuum machine on there. When we're excising tumors and we don't know the margins, then we can put this machine on as we wait for the margin. So it's a temporary machine. It lasts anywhere between 7 to 10 days. Okay, so usually cost is about 20,000 shillings. So somebody will come and put the machine on. So it's very good. It has helped with very chronic wounds that are not granulating. So you can place this on those wounds. Okay. This is basically how it looks like. Again, you can see there's a small machine there. There's a tubing, and then you have your foam on top. It's also been known to use when we do abdominoplasty procedures or general surgeons do the laparotomy and then there's a difficulty bringing skin together. You can place it on top of the incision site to prevent dehiscence. Okay. So we have gone through wounds. So what sort of dressing would I know the ones who do the dressings for the wounds, so they're already hiding. So what would you use here? Any volunteers? What dressing would you? Okay, how would you manage this wound? What would you do?
Seems like we need to clean.
Yes.
And suture it.
Okay, cleaning is good. Now let's say we can't suture it. Let's say the edges cannot come together.
Yeah.
What other option would you have? So just from the talk that I've any yes, who said that? Foam dressing, yeah, that's one. You can do a foam dressing. Remember the foam dressing was to obliterate cavity. So you can cut it, stick it inside, then put a gauze on top. Okay? Yeah?
Gauze packing.
Gauze packing, you can pack gauze as well, that's okay. But gauze, it has to be impregnated with an antibiotic, yeah? Good. Fiber dressing as well, good. Foam, fiber, or the gauze, right? So you see, it's really simple. Once you know they're available, then you can pick. What would you do here? What dressing would you use here? This is a burn patient I've been managing. You can see quite burnt, waiting to do a skin graft. So what can you do? You can see very good. You've seen the biofilm, yeah? Good. Excellent. So what do we need to do? Debride, exactly. So this is when you call the primary physician or the surgeon and tell him, doc, this is a biofilm, you need to plan to debride. Good, excellent. Let's see. Here, what would you do here? How would you manage this?
Irrigation.
Irrigation, yeah. Irrigation is first. You need to get the wound clean. you need to debride, isn't it? You can see there's slough, and then you can see there's that biofilm as well. At least now I'll be very happy when you treat these wounds. Good. This one? Debridement, exactly. You can see, yeah? In the past, this one you would clean nicely and put Actisob, yeah? So now this one has to be debrided, Good. So what other therapies do we have? So we have hyperbaric oxygen therapy, we have stem cell therapy, we can also do fat grafting, we can do PRP. So these are just some of the other adjuncts that we have. I won't stress on this too much. Good. So any questions or anything you want me to clarify? Anything that's raised a question for you? Yes, Doc.
Doc, what's the implication of not removing slough?
Okay.
On a wound, the implication?
So implication is you're just giving fodder to the bacteria. Mm-hmm. Yeah. So as long as it's there, that's one. Then number two, whatever dressing you're going to place on top, the slough will be the barrier between your dressing and the wound base. Mm-hmm. So you'll not be able to get the full effect of your dressing. Yeah, and most of these can actually be done bedside. Like the other wound I showed you, you don't have to take it for debridement. The last one, yes, when it's very, very severe. But the ones where you see a little bit here, a little bit there, you can just take a forceps, just clean it. And what will that do? That will just help fasten the recovery. Yes, Doc? So outpatient you can try if it's an adult patient and it's on the extremities and there's minimal pain, then you can take some gauze with saline and then try to rub it off. But again, that's very painful and then they usually end up with bleeding. Or you can use silver. There's some silver solutions, something like Curion solution. You can pour that and then wash the wound with it. Sometimes it can penetrate the biofilm. But for that you'll have to do a formal debridement. Okay. Usually it forms because the dressings that you're doing might not be adequate. Okay, and then again, remember, our end goal is to close the wound. So again, you need to also ask the physician who is taking care of the patient, when are you closing the wound? Why is there a delay? Why are we dressing? Is the HB low? Is it a financial constraint? So you need to find that out, and then you need to categorically explain to your patient that, look, because of this delay, now your wound is behaving this way, because they'll think you're the one who is making the wound bad. Especially when people change, they'll be like, oh, the one who did last time, now this has happened. So you need to be very clear that your end goal is to close, but now because of ABC, now this is how the wound is behaving. So please make sure you sort out your primary issue. Okay.
Look, we are being discouraged from using antiseptic solutions to do wound cleaning.
Yeah.
Why is that the case?
So basically, for wound cleaning, if you look at literature, just the saline and Ringer's lactate is enough. Okay. Now, why do we use antiseptic solutions? So the betadine that we have here, okay, for example, it's very, very high. The percentage is high. If you look at the percentage, it's very high. So what does it do? A high content of betadine will be corrosive to the wound. So if you pour that betadine on the wound, you're actually making it worse. You're making the inflammation worse. So what do? You have to dilute it. Okay, so for example, for something like Pseudomonas infection, like when you get this green exudate, I don't know if you've been seeing it, yeah? That is Pseudomonas. So what do you do for that? We dilute with vinegar. So you take vinegar and dilute it with either saline or water for injection. So dilute it maybe 1 to 3, 1 to 5, and then you wash the wound with it. For betadine again, 1 to 3. You dilute 1 part, saline, 3 parts betadine, dilute it, and then use that to clean. So it's not against the antiseptics, but it's the way you do it. So you have to dilute it. Yeah. And then if something is highly infected, then you have to go for debridement. And remember, this is literature coming from countries that are they have set standards, everything is working. But remember, we are in third world country where we have delays. You have this delay, that delay, finances. So that's where now the challenges come in. Yeah.
So if at all I must use it, then I have to dilute it.
For betadine, you dilute it. Mm-hmm. Yeah. Or you can use, once you clean with saline, you can use the betadine impregnated gauzes so that it can just sit there. Yeah.
But
Yes.
now,
Yeah.
But now for fresh wounds,
Yeah.
maybe just a fresh cut wound.
Yeah.
To just prep the skin, it's okay. You can use betadine. Of course, they do.
Yes, for skin prep, yes. For skin prep, yes, because you want it to be sterile, but not for the wound itself. Yeah. For preparation, yes, but if you're getting a chronic wound, then you don't need to do that.
Okay.
But yes, for control of infection, when you're doing a procedure, yes, you have to clean with betadine. Yeah.
Okay.
Yes?
Would you ever use hydrogen peroxide for cleaning the wound
So-
if it's infected?
So we have moved away from hydrogen peroxide because of, again, it's very toxic. And then you're not able to control the depth the peroxide goes to. So you'll pour it all over and then sometimes it spills onto the skin. So it tends to create more harm than good. And by the time you're thinking of hydrogen peroxide, then that's a patient that needs some sort of surgical intervention. So if the patient has been managed well, where you get a good history, you've done your dressings well, you'll rarely get to that point, unless for chronic wounds. But you do, we tend to move away from that now.
How often should you disturb the wound?
Okay, that's a good question. So it depends on the status of the wound, okay? If the wound is highly infective and there's a high exudate, then you need to come back within 48 to 72 hours. If it's a nice wound with no biofilm, then you can place a gauze and come back after five days. So it depends on the indication, what the wound is telling you. Yes, sir.
I have 2 questions.
Yes.
One is diabetic wound.
Yes.
Diabetic wound, most of them we don't use betadine.
Yes.
And you've said it's good to dilute it. Is it advisable to use betadine on diabetic wound?
Yes.
The next one
Yes.
is on. Oh, you answer that one as I start with that one, then I.
Okay, fine. So for diabetic wounds, you can clean it with betadine. That's okay, but you dilute it. That's what I'm saying. So we're not against betadine. We're not against vinegar. We're not against these topical antiseptics, but you need to dilute them, and you need to find the right wound. You know, sometimes you have a clean wound, very nice, well granulated, and you're using betadine to clean. So you're not serving any benefit.
The next question is about the burn.
Yes.
According to my experience, if you cover burn, it takes time to heal. But you find most of the doctors, they will advise you to cover even if it's an adult, and it will take time to heal. So what's your advice on that?
Okay, so burn wounds, it depends on what depth you're talking about. You have the superficial ones, you have the partial thickness, then you have the deep. So if it's a superficial wound, within 10 to 14 days it's going to heal. Okay, so how big is it? Is it a small, if it's a small burn on the cheek, you can't go put a dressing there, and it's superficial. So you can use topical antibiotics like mupirocin. You can tell the patient apply that twice a day with a bit of Vaseline, just to lock in the moisture. But if it's extensive, then it has to be dressed, because burn wounds in the first week are highly exudative, and you have to change the dressing every 48 hours. Regardless of what dressing you're using, it's good to change it early because they're very exudative. If it's a superficial partial thickness wound, then that one you need to give it a bit more time, but still you need to dress. The 3rd degree burns, you need to take to theater and get them sorted out. So once you get a burn, it takes about 3 to 4 days, maximum 5 days, for you to know the depth of the wound. So you'll see sometimes you come and you'll see that the area is white in the center and then it's red around. Then when you come back 2 days later, the area that's red is now white. So that means the burn process is still spreading. Yeah, we'll do a CME specifically for burns. So I wanted to just start with this, and we'll tackle that specifically. Yeah.
So, Doc, I have 2 questions. One is antibiotics. So, according to what I've read, literature, the classification of wounds, the clean, contaminated, and dirty. So some say that if it's clean and contaminated, you still don't need antibiotics. So if it's clean and contaminated, you can still do without antibiotics. But others say that as long as there's contamination, you need antibiotics.
Okay, so that's a good question. First of all, for wounds, generally, we don't use antibiotics. Okay, so if a patient comes to you in the OPD and has a wound, antibiotic is not of choice. And why is that? It's because the amount of antibiotic you need to give the patient orally for you to have the concentration at the wound is very high. So whatever you're giving is not effective. Number two, you have wounds that have biofilm. So biofilm prevents the vessels from delivering the antibiotic to the site. And then number three, once you give antibiotics, you're giving the bacteria drugs to form resistance because they're not at the optimal level. So what do? If it's a chronic wound, no antibiotic. Remember, WHO states that if you're going to do an intervention in a clean or a clean contaminated wound, you can give a start antibiotic and that's enough. Okay? But in our setup where we don't have good follow-up, because once you give the start antibiotic, they disappear. When you have good follow-up, that's usually enough. But first, what we do is, if you're intervening, when you're doing a debridement, when you're doing a suturing, it's good to cover with an antibiotic because you've opened up new tissue planes. Okay? So generally, antibiotics are reserved for after a procedure, or if you do a biopsy of the wound and you look at it and the colonies are created at 10 to the power of 5 specified by the pathologist, then that is a patient who needs antibiotics. Even for burn patients, we don't give antibiotics. We don't. There are certain criteria to provide antibiotics called burn sepsis. The burn sepsis guidelines. So you have certain factors that you look. So is the patient feeding, not feeding, vomiting, diarrhea, fever, temperature, and then there are ways you calculate, and then you say this one antibiotic, this one no. And then before giving an antibiotic, as I told you, you need to get the tissue for biopsy, not a wound swab. A wound swab will not give us good results, because if there's a biofilm and you swab the wound, you're not swabbing anything. You're not actually swabbing the wound, you're swabbing that layer. And then the other thing is, where do you swab the wound? Where do you swab it? This is necrotic, this is not necrotic. Then are you just getting pus? You know? So we use biopsy. Biopsy is more conclusive. So again, generally for wounds, no antibiotics. Yes, topical antibiotics is fine. Yeah, as I said, if it's a small wound in a place that you can't dress, sometimes the ear lobule, the face, the eyelid, the nose, those are difficult areas to dress. Okay. So you can use topical antibiotics. That's okay, because you see, it's topical. It's more of a prevention. Okay. Yeah, so you can use it. There's no problem.
And what about silver sulfadiazine and burnings?
Silver sulfadiazine, the only issue with it is that it forms a layer, a yellow layer on top, which can interfere with the dressing and the wound bed. So that's why we use it specifically in Kenyatta because of the cost. That's Damazine you're talking about now. Yeah, and then it has other issues when you use it over larger surface area. It has bone marrow suppression, aplastic anemia. It has a lot of side effects. So we have tried to move away from there. But again, some of the dressings that they'll discuss, maybe that one, like if it's impregnated, then you can use it. That's no problem. Yeah, but the Pinodin dressing that they'll show, the betadine dressing, you can use that for burn wounds. The advantage with that is if it's superficial, you can just place it on top and come back after even 5 days. Post hip replacement, where they're sensitive implants, you can put the betadine impregnated gauze and then come back after 5 days. If you put paraffin gauze with chlorhexidine, you have to come back earlier. By the time you're coming back, the effect is over. And remember, it's not an antibiotic. Chlorhexidine is an antiseptic. Yeah. Any other question? Yes. Yeah. Yes. Yeah.
Now, what is your advice on a deep cut from a dog bite?
Dog bite, don't close. Dog bite, human bites, don't close. Just wash. Even if it's gaping, you don't close. The minute you close a dog bite or a human bite, you've locked in the infection and you'll always get sepsis. We have left them open even for 2 weeks. Even the nose, the ear, you leave it, you treat it. Now you use your dressings. Yeah, you don't close. You'll be very tempted to suture, because if you look at the pathophysiology, the saliva of dogs has a lot of microorganisms, and when you have the bite, it's actually a puncture bite. So the bugs have been delivered much deeper. So those are wounds now where you can use now the betadines to clean, You can actually use betadine very well for the dog bites and the human bites. Yeah, that's a good question. I forgot to put that up.
Okay. I was asking about topical metronidazole.
No.
Or
Flagyl, no. No. People have used topically, people have crushed the tablets and thrown it serves no benefit. Yeah. Flagyl, I don't know where it originated from. I have no idea. But some even use the IV and, it serves no scientific purpose. Actually, turmeric is better, yeah. Yeah, turmeric is better, yeah. Good. So, thank you.
We have so many questions for him. He's always available in the hospital. So, I think we'll make another CME for this.
Yeah.
You all agree on that? So next month, next month we'll have another CME for Dr. Reed. So we'll give our sponsor 5 minutes. We already passed time. They tell us about their products, and then we have our lunch.
Afternoon, everyone. Luckily, most of my products have been mentioned by now. So I'll quickly go through them. And we also have the booklet that allows me to. I'll operate within the 5 minutes because most of my products have been mentioned. I started with a brief introduction or a mention of the company. I want to Globe Pharmacy Limited. Globe has been around has been created for more than 45 years. Actually, it's around 47 by now. So it's a company that has operated within this country for that period of time. We have over 300 products and still growing. Some of them are well known, others are just So lately we've introduced this department or this sector for wound management, and that is a specific reason why we're here today. As you can see, these are well-known household products, the Gravacin, the powder, and the ointment. I'm sure there is no one who has not interacted with the ointment. So we have moved on from this. These are really for very superficial wounds, whether they are burns or cuts, very superficial ones. I'm not going to tell you about the now I'll start with the new ones. This is a plain paraffin gauze. This one is just for dressing the wound. It's not medicated in any way. It's plain paraffin. So I will not give more details about it, as indicated. The purposes are indicated there. And we also have chlorhexidine gauze, very popular also, and biogas. This one has been around.
Okay. This one has been used. I'm sure most of you have also interacted with it. This is chlorhexidine. Brand name is Biograss. Another addition to the Grabacin family. Grabacin is a triple antibiotic. We've talked about the powder, the ointment. Now we also have the tule for the wounds that you need to treat and you want to dress them for quite some time. So instead of going for the first two, you can consider the impregnated gauzes. The next product is the povidone iodine. Brand name is Pinodine Plus. It's a combination of povidone iodine and metronidazole. Someone was asking about Fragile. Now instead of crushing the Fragile, we have provided this solution. We already have a gauze that combines povidone iodine and metronidazole. And just to mention, it is not there in my presentation, we also have plain povidone iodine. It's called Pinodine. So we have Pinodine Plus and Pinodine. Plain povidone iodine and the combination. The next product is SSD plain. It's called Silvozine. And by the way, all these gauzes are available in a smaller size and a larger size. All of them, from Grabacin to povidone iodine plus metronidazole, Pinodine Plus, and now Silvozine. They are available in a small size of 10 by 10 and 10 by 30 or 10 by 40. The next one is a combination of silver sulfadiazine and chlorhexidine. Brand name is Silviclo. Unfortunately, I'm limited with time, so I'll not delve on the details. Doctor has gone through the uses. So where applicable, where you need a combination of SSD and chlorhexidine, an antiseptic and an antimicrobial, you go for Silviclo. Now the newest addition is oxoferrin. Oxoferrin is tetrachlorodecaoxide. This one is mainly for those chronic wounds that are quite complicated. These are some of the details that we've been taken through. I will not have to mention parts of the various components of wound healing where the product helps. Inactivation of macrophages and the results that you get. These are comparison of wounds that have been dressed using oxoferrin and the progress that have been experienced. It is the only, whatever. The next product is another addition that we've brought. These are oral antibiotics, a combination of cefuroxime axetil and clavulanic acid in those two strengths of 250 and 62.5 and 125 milligrams. These are for when you are managing wounds that need oral antibiotics. You can consider this combination. Then another product, an anti-inflammatory that you can co-prescribe with antibiotics is Chimoro. Chimoro is a chymotrypsin combination. It's a combination of proteolytic enzymes. Helps with, it is an anti-inflammatory essentially. So for all the wounds that you might be managing, there are different components that I may not go through for now about how a proteolytic enzyme combination can help in the process of wound healing, whether it's with the clearance of the edema or the penetration of the antibiotics that you've administered. So essentially you co-prescribe with your antibiotic. My last product will be silicone scar removal sheets. This is once the wound has healed completely, you want to now clear the scar. You can use silicone. And we have these are sheets that you just stick onto the scar once the wound has healed completely and closed completely and healed completely. Is where now you go to the clearance of the scar using Scarid. Doctor has used most of these products. That is why he is making a reference to them. I don't know if I'll get a minute to, in case someone has an inquiry to make. Apparently we didn't have a lot of samples for you guys for today, but we will organize how they will be availed in the course of time. So some of them we had only one piece for presenting, but there are some that you can just have a look. Those are boxes of 10 pouches for the dressings, 10 pouches in that box, whether it's a 10 by 10 or a 10 by 40. There are 10 pouches inside, and we say it's peel to open. So when you are applying or when you are using, it's very easy to apply. They are peel to open. So I don't know, if you want to make any inquiry, we'll hang around for quite some time. If you have a personal question that you would want to ask, or if you have a specific indication that you would want to try any of those products and you want us to avail, we'll be around in that corner. So I came with my 3 colleagues. Is Geoffrey and Charles is at the back, and my name is Peter from Globe Pharmacy. And thank you. There are some that we don't have any completely. So for the oral antibiotics, maybe for this one, for the rest we will leave. Yeah.
You can be doing with them the addressing.
Yeah, so that is where I was going. We are giving them for free. We are leaving them behind for free, except 3. Except these oral antibiotics and the oxoferin. Unfortunately, I don't have any other for use even today when I proceed with my own. Yes. So oxoferin, but the rest you will share.
Grace,
Yeah. The rest you will share.
Let's give to Grace, and then Grace for the custodian. So let's appreciate them.
You guys will have a look and then you will take it.
There was 2 p.m. so we started late. So please.
Unless there is silver, you can use it. But in those moderate,
when?
Like stuck out like nothing. Have you seen it? Yeah, it's not a fiber. Yeah. Foam is something that can it's just for the smell. It's just for the smell, and then if it has silver, it can kill the immune. Oh, excellent. Thank you. That's right.
Yes, it was a very nice presentation. You can advantage of Maserati over here. Look at that. This combination is more tolerated and more efficacious. So the dosage can be between 1 TBS, 3 times a day, or 2 BD, or 3. These are